Good afternoon to one and all. Hope I'm audible and hope my screen is visible. On the outset, thank you for Med Talks for giving me this opportunity to speak to the live audience and share whatever little I know. It's indeed an honor and it is a privilege for me to speak for in for what talks which was started off from Dr. K. Agarwal, who's indeed it's indeed a privilege and honor to be presenting here. Uh, I'm Dr. Vinu Sarathi. I work as a medical oncologist in Bangalore Baptist Hospital, which is situated in Hebbal, Bangalore. And I would, through this in next 45 to 50 minutes, I would like to speak how the landscape of oncology has changed, how it is changed for the better, and how it was an unprecedented change from the last 20 years. It is indeed a big difference the way we approach and treat now. And hopefully, I would like to make some difference over the next 45 to 50 slides. So I'll be starting off. So coming to a brief history about what we are saying, so that when I reach the topic proper, we'll have some background. So brief history on how the entire our anti-cancer drug, the approach towards anti-cancer treatment started off. Indeed, initially we were clueless. All we knew, there was a lot of theories floating about cancer. Some people said it's due to body fluid, imbalance of body fluids. Some people said it's a toxin in the body. Some people said it's due to bacteria and an infection. So some people, even they would think it is a curse and they would use black magic and voodoo and whatnot methods. So nobody knew exactly where they are heading towards cancer, what could be the etiology, how to approach it, how to kill it. Nobody knew. So the first efforts, brief efforts, were the initially during 1940s, where a lot of money and time were invested. Even manpower was invested in basically the World War, and not much efforts were towards improvement in science or in towards literature or any of such things. So it was an accidental, or what you say, a serendipitous discovery. So during the World War II, there was a German air raid in Bari in Italy, where John Harvey is one of famous Liberty ships of the US, where it has stashed mustard gas. Mustard gas is a very poisonous, toxic gas which causes lung issues, lung failure, and also causes very intense blistering of the skin and knock out your immunity completely. So one of the German air raid, they found this ship, John Harvey, the Liberty ship of the US, which had stashed up all the mustard gas bombs. And when it air raided it, many of the residents of the ship or the inmates of the ship were exposed this. And when they were hospitalized, they found, when they examined these victims, that they had no counts at all. The blood counts, the hemoglobin, the white blood counts, the platelets had all reached rock bottom, which had almost become zero, and many of them succumb to serious infections. So they found that when you are exposed to mustard gas, your bone marrow gets suppressed, and your hematopoiesis, or your ability to produce blood cells, gets intensely suppressed. So this was a starting point for an oncologist. So if leukemia or lymphoma is a disorder of the bone marrow, where it is due to excessive production of immature blood cells, why can't we use this to suppress them? And this was the idea which started it off, which was an accidental discovery. So, and there was a landmark paper which was published, which is one of the most famous medical journals, which is New England Journal of Medicine, in June 3rd, 1948, where Mr. Sidney Farber, who was a pioneer in acute lymphoblastic leukemia, what we call a white blood cancer, more common in children. He started off and he found that when we use such chemotherapy drugs, we can we can cause the tumors to stop growing. It was not a landmark breakthrough for cure, but this was the first time where they said chemicals can be used to stop cancer growth for at least a temporary amount of time. And this folic acid antagonist, this is also pioneered by one of our own Indians who hailed from Andhra Pradesh, called Subbarao. He was the main person who invented this, which we know as modern day methotrexate, and he helped Mr. Sidney Farber to help in the the earliest successes, even though temporary, but it was a major breakthrough in 1948. And eventually, what happened, that led to more discoveries. And by then, the World War had ended, and people realized that we have this very dreadful disease called cancer, which is not getting enough attention. And we need to be putting in more manpower, more effort, more financial funding also towards this. And in 1958, after all the dust had settled from everything, all the war, everything, so people actually took a conscious effort. It was started by the US, who were financially superior from then on, saying that we have to start a national cancer program. And at the National Cancer Institute, they started the first federal program to promote drug discovery. So that time again, it was like they were like, we have to discover more drugs. The more drugs we discover against cancer, we are going to have important outcomes, or we are going to be successful against cancer. So, and that led to the discovery of what we know as 6-mercaptopurine and vinca alkaloids, which are the next batch of drugs being discovered for cancer. So then next breakthrough came. So till now we knew that Sydney Farber showed that we can have temporary remissions, which means temporarily you can arrest the growth of cancer cells. But can cancer cells be cured with just chemotherapy? So what we had a major breakthrough was we have a tumor called choriocarcinoma, which comes from the placenta from the pregnant lady. From the pregnant lady, where there's a placenta, which is the nourishment tissue to the growing fetus. So that from that rarely we can get a tumor called choriocarcinoma, which is a very aggressive malignancy which can rapidly spread and kill the person. So till then it was a dreadful cancer. But then Mr. Roy Hertz and Min Chu Lee, who was the first person who said that by giving this methotrexate to choriocarcinoma patient, we can actually achieve cure, which means with just a single chemotherapy drug, cure can be achieved in a solid tumor. And this was path breaking till then, because nobody believed till then that a cancer can be cured surgeries, but no a single drug. And so what he said, this tumor secretes something called a HCG, which is like a hormone, a beta HCG. So he said that we can use this to monitor the treatment. So which means lesser this level, the tumor is shrinking. And he said that once this enzyme or this hormone disappears, then we have to still continue chemotherapy further for another 4 or 5 more cycles to kill all the microscopic disease, and then you can achieve cure. But however, the NCI disapproved this theory that he is unnecessarily continuing and poisoning patients with the chemotherapy drug, because his treatment approach was more radical. He said he started the first theory of something what we call a maintenance chemotherapy, which means you achieve what we call a cure, which is documented by absent level of HCG, but then you give another 2 or 4 cycles beyond that. So he gave the earliest framework of a maintenance chemotherapy. But however, that time the NCI disapproved it and said he was unnecessarily experimenting them, and they in fact fired him, and he returned back to Memorial Sloan Kettering, which is the other huge institute, which is the most contemporary, biggest institute of cancer. So this was the earliest reports into maintenance chemotherapy, and chemotherapy can treat and cure the solid tumors. Next, this was Dr. Vincent DeVita, who introduced something called combination chemotherapy. There are other cancers which cannot be cured with just a single drug. He said by combining various drugs which work differently, mechanisms of action, and which have different toxicity profiles, we can include long-term remissions in children. Long-term remission, a fraction of them may even get cured. And he said he introduced the first combination chemotherapy regimen, which was called the POMP regimen. And he's a very big stalwart in oncology. Till today, the books written by him is what is considered the landmark book for oncologists. So he started at the NCA in 1960s, and he is the pioneer, or he was one who initiated combination chemotherapy. Later on, we had the concept of adjuvant therapy. Till then, there was a very famous surgeon called Dr. Halsted. He had started off the trend of doing radical surgeries for breast cancer. He said breast cancer is mainly treated and cured with only surgery. So if the patient recurred, he said probably the surgery was not enough. We have to do a more wide field or extended surgery. So he went on extending the surgery. It started off from the breast, then the axilla, then up to the neck, and sometimes he even started extending his surgery. It was so radical that up to the top, up to the base of your chin, he started increasing the surgical field, and they became very debilitating. They were very mutilating surgeries. But in fact, he found there is no increased survival with just going on cutting off more tissue. So the whole concept came that probably tumor cells are already spread to other distant organs, which can only be cured by giving chemotherapy, because chemotherapy goes through bloodstream to all parts of the body and kills them. So just increasing your surgical fields and doing more debilitating surgery does not add to survival, but rather adjuvant chemo, which means chemotherapy given after a curative intent surgery, is what is going to finally help in improving survival. And this was proven in a landmark study by the National Surgical Adjuvant Breast and Bowel Project by Dr. Bernard Fisher. After this, unfortunately, there was a period of stagnation. Everything was going as per schedule, and cancer people, they found out there's a cure. They found out adjuvant chemotherapy benefits, but we could not get further benefits. And a very famous Landers column appeared in one of the news dailies on April 19, 1971, and they compared cancer progress with. By then, the Apollo program had taken over, and we had successfully, man had landed on the moon, and they said we should have a moonshot for cancer. But unfortunately, we cannot extrapolate something like a scientific improvement, like a man landing to moon, to a development in cancer. So what they said was the Apollo mission actually stood on strong physics and scientific discoveries. They already discovered atomic physics, fluid mechanics before launching a man to the moon. But with cancer, they did not even have a basic understanding of what made cells malignant. So what we were missing was we were going all out to just finding newer drugs, newer toxic drugs which just work by poisoning the cells, combining them, making a combination therapy with 2 drugs, 3 drugs. If 3 doesn't work, 4 drugs. If 4 doesn't work, people said give a higher dose, add on a 5th drug. But we did not have an understanding of how the chemotherapy is working, what makes cancer cells malignant, what makes it different from a normal cells. In total, we did not understand is what is the pathophysiology behind the cancer. So they said, so James Watson, who was instrumental in discovering structure of DNA, he went on a rampage saying doing relevant research is not good research. He said what is lacking is basic research. He said till you understand or think like a cancer cell, know how they proliferate, we cannot find good drugs. And that is what led to a radical change. So this can be very much extrapolated from how people used to think during that period. Initially, when cigarettes were introduced and the tobacco market went on a very big high, people were saying actually smoking is useful for you, in fact beneficial. In fact, there were doctors endorsing the products. They said more than 1 lakh doctors from coast to coast in the US were asked, and from east to west coast, they said smoke this brand of cigarettes. There is no causal claim, which means they said cigarette does not cause any of cardiac disease, neither cancer. So initially they were saying based on independent research, smoking is in fact beneficial for health. But then came the 2 landmark surveys, which was done by Doll and Hill, and what we have the Surgeon General report. So if you see the trend from 1910 to 1920, the number of people smoking went dramatically up because it was always stressed, or the impression was given that smoking is good for health. But then after these 2 landmark studies, they found that actually smoking is so bad for health, and then the number of smokers came down. So this was the mental framework that time, where there was not enough put in towards what is actually the pathophysiology, the basic sciences. And so this can be illustrated by this one example. And then Mr. Richard Nixon, the president, he signed the National Cancer Act of 1971. This marked the beginning of how we thought about cancer. We no longer went hunting behind drugs, but we rather we changed the perspective of first finding out what fuels a cancer cell, what makes cancer cell different from a normal cell, what is it which is driving the cancer cell, and that led to the targeted and immunotherapies, which is the topic of today, which we are going to be speaking a little more in detail today. So the 2 landmark therapies which marked that we had made successful breakthroughs through this new out of the box or the goal directed thinking is Gleevec, which we say as the imatinib, which has revolutionized chronic myeloid leukemia treatment. In fact, today chronic myeloid leukemia patients are said to have a life expectancy equal to that of a normal human being. And the next is by Dr. Dennis Slamon, who invented trastuzumab, which has revolutionized the way we treat with something called a HER2 positive breast cancer. And this birth of targeted therapies began from the 1990s. So, in fact, this was such a landmark thing. It was It was featured in the cover page of Time, where they said there's a new ammunition in the war against cancer, and they showed these targeted therapies like magic capsules or bullets. So how has it changed? So in 1984 to 2003, lung cancer, everything was the same. It was like one chunk of the pie. There was no known type, and there's only one type called KRAS. And then towards 2004, the same pie had broken into three parts. Lung cancer was now known as EGFR positive, KRAS positive, and no known genotype. In 2009, the pie was further fragmented in many more parts. And 2014, and now in 2022, we know it is at least divided into more than 20 parts, which means we no longer talk about lung cancer as lung cancer. We say, is it a EGFR mutated lung cancer, ALK positive lung cancer, KRAS mutated, ROS mutated? Why is it significant? Because when we know we have a type of mutation, we can design a drug against it, and the benefits you get is far more superior than just using conventional chemotherapy. And these days we have seen, even in stage 4, which means they have gone to very distant parts of the body like liver, brain, 30% of them still make it past 5 years, which was unheard of even around a decade ago. So, what were the challenges with their old paradigm of thinking? All these different mutations came under the same treatment bracket. You either treated with this what was traditionally known as platinum doublet, which means you would give cisplatin with along with other chemo, or you added one more drug without really knowing what target you're chasing. And the problem was you had a very small effect. This is the new paradigm where you get the mutation and you give the exact targeted therapy to it, where you know most of them are going to do well and you're going to get a large clinically meaningful effect. The problem with this is the number of people getting ALK positive lung cancer may be less than 5%. So you may have to screen a large number of people before you actually know who is going to benefit from this therapy. So how has our clinical trials or the way the design of our clinical trials changed? Yeah. So what are the potential druggable events in pediatric cancer? If you see pediatric cancers, you can see that if you look at this pie chart, previously all would be treated with same. They would go undergo surgery, chemotherapy, or if it's a blood tumor or leukemia, they would just get multiple cycles of combination chemo. But these days, again, we are looking into what mutations are driving them. And this study, which is published in a very famous journal called Nature, said almost half of the pediatric cancer may have a druggable target. So, what is exactly precision medicine, where we are heading to? So, precision medicine means the days when cancer patient, when we said one size fits all, may soon be thing of the past. Precision medicine is a personalized medicine. Okay, so we do a molecular testing, we do a genetic testing, and to determine exactly which drugs work or which have the best chance of working. So we do not take lung cancer as a homogeneous entity. We take what mutation is fueling it, and do we have a drug against it? Can we give the drug, and that will lead to a superior outcome? So this is what is precision medicine. No longer we are going in the future. I don't think we are going to be saying, oh, he has lung cancer or kidney cancer. We are going to be saying he has a this mutated kidney cancer, he has a this mutated lung cancer, or he fits into this group of mutations. I think the future is going to be completely different the way we characterize tumors. So one of the it isn't actually new. In 1970s, there was a lot of trials being done on breast cancer, especially because even then they knew it's being fueled by hormones. So they found that tamoxifen was first approved in 1977, where they found by giving tamoxifen, which inhibits the estrogen receptors, the cell proliferation can be controlled. But however, it worked only in the group of patients who are hormone positive and not in the hormone negative subset. Ever since we have progressed significantly, these are the targeted therapies approved for various cancers from bladder, breast, colorectal, cervical, pancreatic, name it. Everywhere you have different targets and targeted therapies approved, and these work far superior to just the conventional chemotherapy. So these are the ongoing trials. For example, we have a BRAF, which is a mutation seen in around 5% of cancers, and we see 298 trials are going as of May 2020 on these markers. So it's not about is it is it lung cancer, breast cancer, colon cancer? It is like BRAF mutated cancer. This is how the nomenclature is going to be changed in the future. It's not going to be, do you have lung cancer? Do you have a BRAF mutated cancer? And irrespective of which site it is, it may be brain, it may be lung, it may be colon. If you have this mutation, you will be, you will have a better outcome with a drug targeted against this mutation. Similarly, you have various targets like this, for which if you calculate everything, I think close to almost 4,000, 5,000 studies are going on just targeted therapies. So this is the new paradigm shift. So yeah, coming to the next slide. So tissue agnostic treatment. Tissue agnostic treatment means you are not really bothered from where the tissue is arising. Is it a lung cancer? We are not bothered. Is it colon cancer? We are not bothered. If it has this mutation, this drug called pembrolizumab, which is immunotherapy, it's already approved across many different subtypes. If you have this MSI high or a microsatellite instability high, which means your tumor is very immunogenic, you are likely to benefit from this treatment, and it's approved already. It's already approved. Similarly, larotrectinib for something called NTRK fusion, entrectinib for NTRK Al-cross fusion, and various other drugs which are in the pipeline. So very soon you are going to have something called a mutation-directed therapy rather than therapy against a specific site of cancer. And how has this changed the way we design drugs development or design clinical trials? Previously, this was the model. So we start with stage one where more than you, it is basically like a funnel model. You start with a huge number of compounds. It is like a bottleneck, but finally you come out with only one successful compound. At stage one, if you start with 10,000 compounds and you spend almost 5 years with that, by the time you have exhausted 15 years, you have come out with only one compound, and that also you don't know how successful it is because it's not specifically targeted. But all these have been cleared, all these have been filtered based on just trial and error. So this was a one size fit all medicine, where there are very classic examples like schizophrenia, where there's an antipsychotic drug called aripiprazole or esomeprazole in heartburn, rosuvastatin in high cholesterol, which fluticasone in asthma, where most of us would have heard. The problem with these are these such 90% of the top selling medicines, they unfortunately work in only 50% of the patients, because they all were approved or they came through trials which were just started on a trial and error basis on some hunch. They were not really a goal directed or a target directed trial like we have today. And almost 30, and we didn't really know the full side effects, and almost 30% of acute hospital admissions every year are due to side effects and adverse effects of these drugs, which came through one size fit all type of trials, where hardly 50% of them got the benefit. So what is precision oncology? You collect a cohort of people, you extract the tumor DNA, you map out, you completely molecularly profile it, and then you see for this group of people with this mutation, you give the pink capsule. For this mutation is the blue capsule or the blue targeted agents, and it's not a one size fit all, rather than it is a different size for a different cohort. So what are the new trials called? They are called umbrella and a basket trials. So the umbrella trial is where you have one type of cancer with different mutations. So you take all lung cancer, put it in under one umbrella, and for a different type of mutation, you give a different drug. And likewise, basket is where you have multiple cancers, but they have a single mutation. And if they have the blue type of mutation, you give the blue drug. If they have a type of mutation, you have the green drug. So here you are first identifying what mutation, what is actually driving the cancer. You are designing a drug against that mutation, and then finally giving that cohort of people with that mutation the specific targeted therapy. So this is our future. This is the National Cancer Institute has recently started the MAT schema, where they take the tumor tissue, they genetically sequence it, and they see if there is any actionable mutation detected. And that patient is going to be started on the specific targeted therapy. Then they are going to be reassessed. If he is having a good response to that therapy, he is going to be continued on that until it is effective. If he progresses on the therapy, again he is going to be checked for any other mutation. Is there any other current targetable therapy available for it, and going to put on that targeted therapy. So this is the way contemporary studies are being done, where the target is first being identified and then the therapy is being started. So this is how we have progressed, where 3000 BC to up to 1890s, we thought the bigger the surgery, the better the outcome, which was proven to be wrong. Then Madam Curie, with the invention of the X-rays, and then the radiotherapy came in, where Kaplan used it for Hodgkin's lymphoma and got very good cure rates. 1940, the error of chemotherapy after mustard gas was found incidentally. Targeted therapy have started off in 1980s, and 2010 onwards, the immunotherapies have really taken off. So what started all this was mainly the Human Genome Project in 1990, which could very successfully map out the genome over 15 years. That led to multiple cancer genomes being mapped successfully and included in the Cancer Genome Atlas. And when we knew which mutations are fueling tumor, the accordingly research could be done to target those mutations. So what are we targeting exactly? We are targeting the tumor microenvironment, not just the tumor. We are looking at the tumor microenvironment to see how many immune cells are there. What are the type of immune cells? Are they helping the tumor, or are they helping the body fight the tumor? What is the immune signatures? What is the total subpopulation, which we have a scoring system? Then the tumor cells we see, are they, what is the burden of tumor cells? Is there something holding back the tumor cells from getting attacked, like a PDL1 or a CTLA? And we are also seeing circulating factors, the blood counts, the immune cell phenotypes, the exosomal or the soluble protein compounds, host related factors, lifestyle, metabolic, other metabolic, microbiome, which is really taking off, saying the body's helpful bacteria which constitute its colon and mouth, do they play a role in immune mediation? And of course, germline, almost 5 to 10% can be hereditary and germline. So those we are looking at. And of course, even imaging characteristics like PET CT and the newer nuclear images. So how has this changed the cure rates? If you see the 5-year cancer survival rates ever since the invention of the targeted therapy, you can see a dramatic improvement in cancer survival from 50 to almost 67%. So this was, if we had stuck around with the old way model of thinking, maybe we would never have progressed. Prostate survival is greatly enhanced, so to thyroid, melanoma, breast, kidney, non-Hodgkin's lymphoma, and they have seen even the 5-year survival in cancer rates in US dramatically increasing to more than 67% with the advent of targeted therapy. And even a recent, the NCI only has brought out the record saying newer drugs have accounted for 50 to 60% of increase in 6-year survival since 1975. And this has been how it has, as we have progressed, we have stopped looking for chemotherapy drugs, but rather we are starting to look for targeted therapies. And this has been the way forward since 1977, and especially since the advent of rituximab and imatinib, it's really taken off in a big way. Coming to immunotherapy, immunotherapy is an interesting fact, because we always know that every day a lot of mutations is being produced in our body due to sunlight or toxins which may be in the food we eat, in the air we inhale, or we may be infected with the virus which can cause some amount of mutagenicity. Aging is always, mutations keep piling up, or random errors in just cell replication. But every day we are producing mutations, but every day our immune system are recognizing and killing most of the mutations. But when the body is or when the cancer cell or when the mutated cell escapes immune recognition, it can lead to uncontrolled cell production leading to cancer. This has always been known. So we always know the first line of defense in cancer has been our immune system. And the earliest proof was Dr. William Coley, who's known as the father of immunotherapy. What he did was he mixed a variety of toxins from Streptococcus and Bacterius prodigiosis, and he found that when you inject this bacterial toxin into a body to fight against the bacteria, toxins, a body's immunity is enhanced, and that immunity may in fact go and cure the cancer also. And he actually said he's for 15 years he's tried his cocktail of toxin and has cured almost 150 patients in 150 patients in 430 cases, which is actually a very very high number even compared to today's cure rates. So in fact, his earliest case was Mr. Fredstein, who was a 31-year-old house painter. He had a big mass or big cancer mass over left cheek. 5 surgeries done over 3 years, but it kept coming back. He had a deadly infection of the skin graft, and he found that as the infection settled, the tumor also melted away. So what he proposed was the infection made the tumor hot. By hot, we say that the infection made a lot of our immune cells infiltrate the tumor, and that caused even the tumor to shrink away. So he was the father of immunotherapy. His recipe was mixing some meat, water, salt, peptone, bacteria. He had no understanding of immune system, genes, or mutation. And but the problem or setbacks for immunotherapy then was his recording and the way his reporting was very inconsistent. Some people said half of his patients recovered. Some people said only 20 out of 93. So people didn't take him seriously, and he was relegated to the back. So hence, this was the setbacks for immunotherapy where the FDA did not acknowledge it as a cancer therapy, and hence it was just put under covers for a long time. These days, we know immunotherapy has changed dramatically different. We know initially in the lymph node that the antigen presenting cells brings a chunk of the tumor, the tumor tissue, and it presents it to the T cell, which then gets activated. So the cancer can block the activation by some of the by a ligand called CTLA4. Then the activated T cell goes to the tumor and then can kill the tumor. This can again be blocked by the tumor by something called PD-1. We know the deep molecular aspects of this, and we have specific antibodies which we have detected, which can bind to these, release the immune blockade, and lead to active cell killing. So this is how it. This is a general outlook how what I had explained in the previous slide, where in the first step there is release of cancer antigens picked up by antigen presenting cell, goes to the lymph nodes, presents it to the T cell, which can be blocked by CTLA by the tumor, but we have anti-CTLA agents which again restarts the immunity. The T cells go to the tumor, infiltrates the tumor, and then kills the tumor. That can be blocked by PD-1 by the tumor cells, which we have anti-PD-1 agents today, which are very specific immunotherapies. So how do we find which group of patients will actually benefit from this therapy? We have a specific IHC marker called PD-1, which we stain the tumor tissue. We see for the tumor cells if it's actively staining like this. Usually for different tumors we have a different score, but we usually say anywhere 1 to 10%. Anything it stains more, our immunotherapies may be very well efficient in such tissues. So this is one of the staining methods which we use. It is not fully foolproof. We do have some places where it doesn't stain and still it works. We are still working on why it's such an imperfect marker as of yet. So how has this dramatically changed? In bladder cancer, previously the survival was less than 8 months, but with immunotherapy, and if they have a good score, then we see that the survival is not even reached, which means even despite 18 months of follow-up, the patient is going on and on, which is almost doubling of survival, which we never had. And this was a trial done on atezolizumab in bladder cancer. What are the future immunotherapy here? We don't just have checkpoint inhibitors. We have something called adaptive T cell transfer, where the tumor biopsy is done. The T cells, the immune cells infiltrating the tumors are removed. They are expanded with interleukin 2, and then so we select only the batch of tumor cells which are already infiltrating the tumor and having good effect. So then we deplete this body of the other lymphocytes. We expand this, form an army of the T cells which are specifically only attacking the cancer cells, transferring it to his body. It's called adaptive T cell transfer. And these days, very much in the news, something called CAR T, which is a chimeric antigen receptor T cells, which means this is the normal T cell receptor. You are taking it out, you are making a chimeric antigen, or you are redesigning the receptor to recognize only the cancer cell. Then you are putting it into a vector like adenovirus, and then you are injecting it. So now this T cell is designed only with one thing in mind, to kill the cancer cell. So you have first generation, second generation, third and fourth generation of CAR T cells, where the designs get more and more complex. As the generation proceeds, we have more co-stimulatory molecules added on. We have other cytotoxic chemicals added on, interleukin 4 receptor added on. So the CAR T becomes more and more reactive and more potent. What is the more future? The future is going to be individual treatment, not just like which cancer has which mutation. We may be treating each patient individually, saying even two patients of lung cancer with same mutation might behave differently. So we are going to treat each individual differently, which is called personalized vaccine. So we take out the tissue sample, we sequence DNA, we identify what specific neoantigens are there, which is present on the tumor cell. we develop a vaccine to it, and we inject the vaccine to that specific individual with that specific mutation profile, and then we immune monitor. So this may be the future where not just we are characterizing the cancer based on its which mutation it has, but based on every individual having a different mutation type. So how is it going to the future? These are the hypothetical what people said till now. We just targeted chemotherapy and immunotherapy. We had reached this far. Next, we are going to be combining immunotherapy, target therapy. We may combine two immunotherapies. We may combine a vaccine and an immunotherapy. And in the future, the curve is projected to get higher and higher and plateau higher. And we may be actually expecting far greater efficacies and far greater cure rates in the future. This is again a chart showing how we have developed from radiation to surgeries to chemos, and we are in the era of genomic profiling, targeted therapy, and immunotherapies. So this has been our whole conundrum of evolution where we have always are we there yet? I don't think we will ever be there yet. But one thing for sure, we are definitely on the right path. With every passing decade, we are realizing we are rethinking about cancer and in general about how we are progressing towards therapeutics. We are rethinking, we are finding new ways, new models, and our cure rates are definitely improving. So we are on the right path. And recently, also, we would have seen that article where immunotherapy showed complete cure rates in 12 patients, even though it's not a large number, but which means we are all on the right path. We have never seen complete cures like that in immunotherapy. Your time. Yeah. And stop sharing the slides. Thank you.